and it's wonderful to be here and be able to share a project that I conducted as part of a placement at the University of Toronto around about this time last year. So I was based in Toronto for 3 months as part of my PhD. So, for those of you who don't know, my name's Claire, and I have just finished my PhD at University College London, and I was based in epidemiology and public health. And my research interests are really around understanding the health needs and experiences of women who have their children taken into care. So a lot of my work is based in an English context, but the project I'll be presenting today is in a Canadian context using Canadian data. And I hope that you'll be able to see the value of this work and the way in which administrative data can be used for public good, as Emma said at the beginning. Um, so I'll kind of guide you through this project, and I'm really open to discussion and comments and feedback at the end. So I will be presenting on maternal disability and newborn discharge to social services. And just to provide a bit of context to that study, historically, people with disabilities have been subject to various forms of discrimination and social exclusion, including in their ability to become parents. So, for example, historic practices such as segregation, institutionalization, or involuntary sterilization. And in recent decades, there's been important social and political movements to improve the rights of people with disabilities. And as such, the rates of people with disabilities becoming parents is increasing. So it's estimated that in Canada, around 1 in 8 pregnancies are to women with a disability, whether that be physical, sensory, or intellectual. Despite progress, these mothers face many structural, social, and health related barriers to parenthood, including assumptions about their family planning intentions and in their parenting ability. There's also recent evidence to suggest that parents with disabilities are at increased risk of obstetric and neonatal complications, and have higher rates of poor outcomes throughout pregnancy and birth. So, in the context of this study, I was interested in looking at the role of children's social services. So, children's social care, child protection, equivalent services across the world have a duty to protect children who are deemed to be at risk of harm, whether that be due to abuse, neglect, or where there are concerns around parenting capacity. So, what does this mean for parents with disabilities? Well, the literature is quite clear that parents with intellectual and developmental disabilities are overrepresented internationally in child protection cases. So the prevalence varying between about 26 to 87%. And these parents also have higher rates of newborns entering care. Newborns being discharged into social services is of particular concern. It really leaves little time for parents to demonstrate their ability to parent. And it's extremely traumatic for both mothers and babies and can impede on immediate parenting practices such as bonding, breastfeeding, attachment, and has longer term consequences for newborn development as well. But we know far less about the impact of other disability types with children's social care outcomes. And we also don't have much insight as to whether these separations are sustained after the birth and what other factors impact or influence the likelihood that a newborn might be discharged into care at the point at which the mother gives birth. So that's where this research sits. I was interested in understanding if newborns of mothers with disabilities were at an increased risk of being discharged into social services compared to newborns born to mothers without a disability. And then I was also interested in looking at whether these separations are likely to be sustained. So at 12 months following birth, if mother and baby were still living separately. if families experience more than one newborn being discharged into care, and if that's more likely for families where a mother has a disability, and to look a little bit at characterising the factors that might predict a newborn being discharged into social services. So this was a population-based study using administrative health data. I worked with ICES, which is an organisation who host an inventory of coded and linkable health datasets from across the region of Ontario, which is highlighted here on the map where Toronto sits. So it brings together much of the publicly funded health services from across the Ontario population and has coverage from the kind of mid 80s. So it captures health service records for around about 13 million people, with about 140,000 births per year, just to give some scale. As part of this project, we drew from different data sources, working with a data analyst at the ICES. And that was inclusive of the National Ambulatory Care Reporting System, which had information on emergency department visits, the International Classification of Diseases, or ICD-10 codes, as well as the Ontario Health Insurance Plan, which was information related to outpatient physician billing claims, the Ontario Mental Health Reporting System, which captured information on Diagnostic Statistical Manual, or DSM, diagnoses related to mental health. The Canadian Discharge Abstract Database, which again was around hospital admissions and ICD-10 codes. And the Registered Persons Database, which was information on sociodemographics such as date of birth, residential postcodes, and also linked to census data. So I wanted to look at a cohort of all newborns between the years 2008 and 2020 in Ontario, Canada, and look at the rates at which those newborns had mothers with a disability. So I used algorithms that had been previously used in research conducted using ICES data, that looked to categorize disability on similar presenting needs. So we considered a mother to have a disability if she had a relevant diagnosis in 2 or more outpatient physician visits, emergency department visits, or hospitalizations before conception. And we categorized these disability types into physical disabilities, so thinking about some forms of congenital anomalies, musculoskeletal disorders, neurologic conditions, or permanent injuries. Women with hearing loss or vision loss were coded as having a sensory disability. Those with autism spectrum disorders, intellectual disabilities, fetal alcohol spectrum disorders were coded as having intellectual developmental disabilities. And if a woman had more than one, or were coded in more than one of those categories, they were coded separately as having multiple disabilities. So the main outcome of interest for this project was looking at whether a newborn was discharged into social services at the birth event, so at the hospital stay where the birth happened. The data that we had access to was healthcare data. So, as indicated in the database breakdown for the ICES cohort creation, we didn't include any social care data. So the information we have on whether a newborn was discharged into social services was based on a proxy indicator of whether that newborn had a discharge into social services in their hospital record. So that was if the discharge flag listed social services, if there was a diagnostic code for institutional upbringing in the newborn record, or if the newborn was transferred from the hospital to a Children's Aid Society or children's home. So it was quite a narrow definition for that outcome. I also wanted to look at whether those separations were sustained at 12 months, as mentioned. And so I looked at the newborns that had the outcome of being discharged into care and also saw if they had the same or different postcodes as their mothers at 12 months. There's many factors that are relevant to this research question, and so I looked at including different covariates as part of the modelling and to describe the differences in characteristics between different groups. So firstly, in terms of sociodemographics, it was thinking about maternal age and whether it was her first baby, the area, the neighbourhood income quintile, whether that family were in receipt of social assistance or benefits, if they lived in rural or urban areas. I also looked at other health characteristics, so thinking about chronic conditions, mental illness, substance use disorders in the mother's health record. And finally, I looked at perinatal specific characteristics. So, whether there were any obstetric complications or neonatal morbidities, whether the newborn was born preterm, and also whether the mother was in receipt of adequate prenatal care. So, that was a calculation of the time at which the woman accessed her antenatal health care, what point in the pregnancy that was at, and how many appointments they had before the birth. So to look at the differences between these groups, I conducted initially some descriptive work looking at kind of frequencies and percentages. And then I conducted a modified Poisson regression looking to estimate the relative risk of a newborn being discharged into social services, comparing newborns of women with disabilities to those without disabilities. And in this, we adjusted for clustering using applied generalized equation modeling. So to ensure we weren't capturing mothers, for example, who had multiple newborns discharged into care. But to look into that question further, I conducted a separate analysis looking at all mothers in the cohort who had had more than one baby over the study period and looked at the odds of recurrent removal within families. So hopefully that gives you a broad sort of overview into the methods. And now I can present some of the results from that study findings. So firstly, just to give you some insight into the cohort and their characteristics. This study included about 1.2 million women or newborns of women without disabilities, around 114,000 newborns of women with physical disabilities, around 38,000 newborns of women with sensory disabilities, around 8,000 newborns of women with multiple disabilities, and the smallest group was the intellectual and developmental group, which had around 2,000 newborns of mothers with those coded disabilities in their records. So, what do we know about these women? What does the data tell us with regards to their sociodemographic information? Well, as you can see here on the bar charts, there are higher rates of young motherhood among the intellectual and developmental disability group. There's slight higher rates among other disability groups, but as with the social assistance and the deprived areas, you can see this really pronounced rate of or increased rate in the intellectual and developmental group. In terms of maternal health, a relatively similar picture where you see higher rates among the intellectual and developmental group and also in the multiple disability group. So you can see here that women with multiple disabilities had higher rates of chronic conditions compared to other groups. And again, in the substance use disorders, those with intellectual and developmental disabilities and multiple disabilities had higher rates than the other disability groups and the group without disabilities. In terms of pregnancy and birth characteristics, there were a higher rate of obstetric complications, rates of preterm birth, and of neonatal morbidity among the intellectual and developmental disability group again, and in the multiple disability group as well. You can see here that the no disability group had the lowest rate of obstetric complications, preterm birth, and neonatal morbidity among all of the categories. Okay, so now for the main analyses, which looked to estimate the relative risk of newborns being discharged into social services at the birth hospital stay. So compared to newborns of women with no disabilities, newborns of women with disabilities were at an elevated risk of being discharged into social services, even after adjusting for the health and social care factors that I described and as part of the covariates. So for newborns of mothers with physical disabilities, there was a 50% increase in likelihood of being discharged into care. For those with sensory, it was 30% more likely. For the multiple disability group, they were 3 times more likely. And for the intellectual and developmental disability group, those newborns were 5 times more likely than newborns of women without a disability to enter care at the hospital stay. So you can see here on this forest plot that the intellectual and developmental group and the multiple disability group really have this elevated risk. But across all disability groups, there's an increased likelihood of being discharged into care when compared to the no disability group. In terms of sustained separation, as mentioned, I was interested in looking to see if at 12 months postpartum, so after the birth event, women were living separately from their newborns, using an indicator of whether the postcode was separate and if that newborn had been discharged into care. And again, compared to newborns of women with no disabilities, newborns of women with disabilities were at an elevated risk of experiencing this sustained separation at 12 months, even after adjusting for the health and social care factors mentioned. So for physical disabilities, that was 60%, sensory disabilities, 20%, multiple disabilities, 3 times more likely, and for the intellectual and developmental disability group, it was 6 times more likely that those newborns were discharged into care and still separated at 12 months compared to those without disabilities. Another thing I was interested in looking at was the odds of recurrence within families. So, seeing if a newborn was discharged into care, if it was likely that they would also have a sibling that was discharged into care. So, this wasn't looking at multi births, so twins or triplets, it was looking at separate birth events, but each of those birth events resulting in the newborn being discharged into care. And so, looking into this, among newborns of women who had more than one baby in the study period, so I looked to a specific cohort of women who had had more than one baby, the risk of having a sibling discharged into care for women with physical disabilities, they were over 90% more likely than those without. There was no difference in the sensory disability group in terms of the odds of recurrence. For multiple disabilities, it was 4 times more likely that that newborn would have multiple babies in their family or siblings discharged also into care. And for the intellectual and developmental disability group, it was over 8 times more likely that those newborns would have siblings that were also discharged into care. So with an adjusted odds ratio of 8.74. So as mentioned at the beginning, there's lots of kind of wider factors that might impact on why children are discharged into care at the birth event. And I look to conduct analyses of all of the covariate variables, looking at their association between those variables and the outcome of being discharged into care. So, for example, looking at maternal age and sociodemographic factors and maternal health and the perinatal factors as well to look at the associations with the outcome. I conducted these analyses within each disability group. So I looked at, for example, all of the births among the no disability group, all of the births within the intellectual and developmental disability group. And what I found was relatively consistent across all of the groups, in that the strongest predictors of having a newborn discharged into care was that the mother was young, so that is between 15 and 24 years old. That the mother was in receipt of social assistance or receiving state benefits. That was a proxy indicator, again, with a particular flag related to women not having to pay for their prescriptions. If a family was living in a low income quintile, so related to sort of neighborhood level deprivation. Also with regards to maternal mental illness and substance use disorders, and that was within the 2 years prior to that birth, there were strong associations between a history of mental illness and substance use and a child being discharged into social services. Importantly, there was also an association between women receiving inadequate prenatal care and the likelihood of that newborn being discharged into care also. And the final predictor was neonatal morbidity. So complications with regards to the newborn's health at the point of birth and the association with that newborn then proceeding to enter care. So hopefully that'll paint some sort of picture of the sorts of factors or the characteristics that we're seeing statistically as important in the outcome of having this newborn discharge into care. So I want to spend some time thinking a little bit about what this means and what these findings tell us. Um, so firstly, I think that there's a real need to consider the intersectional disadvantages and social vulnerabilities of which disability status does play a role that increase the risk of children's social care involvement for families. So our findings seem to suggest that women might benefit from some additional tailored family-centred services that might target the social and health inequities, as well as the perinatal stressors such as newborn health issues. And I think that what's key to this work is we know that children's social care play a really crucial role in protecting children where there are risks of harm. And these findings generate evidence that this is happening or more likely to happen among women with disabilities. There's no evidence to suggest that women with disabilities neglect or abuse their children at a higher rate than women without disabilities. And there's a lot of evidence to suggest that parents with disabilities can parent well and safely, particularly when given the right support. So I think these findings really illustrate this health equity issue around which families are experiencing earlier and more intrusive children's social service involvement with their family life. So in terms of what that means for women, as mentioned, I think it's about considering how services can meaningfully support women with disabilities as they become parents. So thinking about those systemic challenges and assumptions around parenting intentions and practices. And it's important to consider, especially from contextualizing with qualitative literature, we know that women with disabilities describe fearing that assumptions around their parenting abilities and feeling judged about their parenting practices. Importantly, women have also described feeling as though their needs are largely unmet in perinatal healthcare. So it's thinking about how we can tailor interventions to address disability specific needs, but also address the factors that have been shown to increase the risk of newborn separation. And that's really important to think about because we know that many of the issues presented here, such as living in poverty or lack of social support, have been demonstrated as risk factors, these are amenable to intervention. So these could be supported and mitigated through comprehensive health and social care. And I think also what we should note is the need for specialist training for health and social care professionals who support these families, particularly in the perinatal period and in the antenatal healthcare. So I just want to quickly reflect on the um, relevance to the UK context or the context in England. As mentioned, most of my research has been looking at the needs and experiences of women in the UK and in England. Um, and I do think that there are some interesting parallels and learnings that are relevant to health and social care practice here. And there's many studies to kind of look to, but I flag this specific report because it's very recent. It was published last month by researchers at Oxford Brookes University, looking at babies in care proceedings and what we know about parents with learning disabilities or difficulties. And what I think's interesting is that this is a different context concerning different systems, using very different data. But to an extent, we're seeing similar findings that there's this overrepresentation of parents with particular difficulties or needs that are being underserved in the children's social care services, and where there are missed opportunities for support that might help families stay together where it's safe to do so. So in this report, it was estimated around a third of parents with a baby undergoing care proceedings had a learning disability or difficulty. So I think just illustrating that these issues aren't on the fringe of health and social care practice. It's ingrained in all of what we do and how practice impacts disproportionately on these families. And I'd like to finish or conclude by addressing that this project was a really small puzzle piece of a really complicated picture, and there are many limitations or caveats that we should keep in mind when interpreting these results. So, firstly and importantly, to think about the data that wasn't available as part of the ICES health data inventory. So, really important demographics around Indigenous status and ethnicity. In the Canadian context, Indigenous status is extremely important for thinking about the risk factors for children entering care. In Canada, about 50% of children in care are Indigenous. And in regions where there are higher proportions of Indigenous peoples, for example, Manitoba, up to 90% of children in care are Indigenous. So missing this information is also missing that part of the picture to help understand, especially around intersectionality. It's also important to think about how the health indicators or the disability codes that we have access to are only those that are known and captured in services. For many reasons, women may not have their needs recorded in a way that would then be captured as part of this analysis. And so it's really thinking about how these data don't provide insight into the lived experiences of women, family, or the practitioners who are making decisions around the family's outcomes. So I think there's a lot to do in terms of mixed methods approaches and trying to understand how to bring in qualitative testimonies and literature to understand the experiences of families where a parent has a disability and there is that children's social care involvement. And importantly, there is no social care data included in this work. So, as mentioned, the discharge into care was a proxy variable created using healthcare data. And of course, that also means that we're missing a lot of information around what happens after the woman leaves the hospital. For example, if a mother and baby are discharged home together, but children's social care become involved when that baby is 1 month, 2 months, 3 months old, they wouldn't be captured in this study. So I think there's an underrepresentation likely of the level of need and the level of involvement from children's social care. Um, this uh, study has just been published in the International Journal of Population Data Science, if you're interested in reading more. And the code lists for disability are all available in the supplementary material, if that's something that's of interest to you as well. And there was a recent article published last week as well in a local Ontario news outlet looking to discuss further the impact of what these results mean for local practice. So I hope that wasn't too speedy, but gives you a sense of what this project was and what the findings were. And just to finish by acknowledging the support from my supervisor in Toronto, Dr. Hilary Brown, as well as the funders and collaborators, including mothers with lived experience of disability and parenting. Thank you very much.